It is just an unbelievable honor and privilege to be podcast interviewing not Pierre Fichard, not GV Black, but Peter Dawson. Unbelievable. Peter Dawson is considered to be one of the most influential clinicians and teachers in the history of dentistry. He authored the best-selling dental text, Evaluation, Diagnosis, and Treatment of Occlusal Problems, which is published in 13 languages. His latest book is entitled Functional Occlusion, From TMJ to Smile Design. He is the founder of the concept of Complete Dentistry Seminar Series, SM, as well as the Dawson Academy. In addition to numerous awards and special recognitions, Dr. Dawson is a past president and life member of the American Equilibration Society, a past president of the American Academy of Restorative Dentistry, and the American Academy of Aesthetic Dentistry. I don't have a single dentist friend in my life that doesn't think you are their number one role model, leader, idol. It's just a huge privilege. So let me start with this first question. How do you think dentistry has changed from when you first entered it to now? Has the profession of dentistry got better? Is it the same, or is it going the wrong way?
Oh, I think it's unbelievable what's happened in dentistry. You know, one of my major themes that we teach is that usual and customary dentistry has continued to get better through the years, but it isn't anywhere near as good as it should be and could be. So I think it's gone in two different directions. And I think a lot of dentistry falls short of where it should be because of cutting corners and not understanding a lot of the principles of complete dentistry. And so that's what we try to fill in that void with the dentist, to help them understand that there's a whole lot more to dentistry than just filling teeth. We teach that dentists today should be the physician of the total masticatory system. And in fact, if you're not aware of the interrelationships between the teeth and the joints and the muscles and all the other parts of the masticatory system and how to bring all that into harmony, you can't even be a good tooth dentist. So we have to get that point across, that the thing that we find missing in the vast majority of practices is any understanding of occlusion, which is the dominant factor in whether an occlusion holds up or is comfortable or functional.
Do you think the dental, 2 months ago, we just had 6,000 kids graduate with a dental degree in the United States. Do you think they were adequately trained in occlusion?
Absolutely not. It's our experience with the Dawson Academy, where we're seeing thousands of dentists every year, interrelating with them, finding out what they know, what they don't know. And now Dawson Academy is worldwide. We have academies all over the world. So we're seeing internationally the same thing. Dentists just don't have an even adequate understanding of occlusion. No, and they're not being taught. It's the rare graduate that gets out of dental school with the real important understandings that they need to be predictive in what they do in dentistry.
So, if podcasting is mostly younger people, so everybody we're talking to right now is probably under 30.
Yeah.
And so it, guys our age read books, and kids under 30 read audio, listen to audiobooks and listen to podcasts. They always, they'll tell me this. They'll say, well, if you talk to 10 endodontists, they pretty much agree. If you talk to, you know, many of the specialties, they pretty much agree. But they find the occlusion camps very, they don't really agree. And their specific questions are, they feel that the first fork in the road is, do they go neuromuscular or do they go CR? Why do you think the occlusion camps are not as harmonious with each other as the endodontic camps?
Well, occlusion is a complex subject, but I think there's a very definite answer to your question, and that is that dentists do not understand how the total masticatory system works in harmony. And as a result of not having a background in the relationship of occlusion to the temporomandibular joints and the muscles and all this, they have a failure in a lot of the so-called occlusal treatment that they do, or it's a let's try this and see if it works kind of thing, and then everybody has a different opinion. And I think a lot of orofacial pain has been kind of stolen by the concept that all orofacial pain is psychosocial stress, something which I completely disagree with. We can classify precisely, exactly what's wrong with any TMJ today. There's no guesswork required. We can fix almost everything, and we can do it very conservatively. Yet we see dentists consistently putting their patients through, well, you mentioned neuromuscular dentistry. I see that almost as a fraud because it has no relationship. The way we see it being done, it has no relationship to how the joints and muscles and all work, and how the harmony of the teeth with the completely seated joints work. So they try that because they don't have any background to evaluate it, and then they go off in tangents because of false promises and get people in trouble.
So, what if right now she's listening to you and she's saying, I want to learn more about TMD? Where would, obviously you're up on the 5th floor and she just walked out of dental school, she's on the 1st floor. Walk her up the stairway. What would be her first step? Would you recommend? What do you think the first thing she should do to learn more about this?
Has to start at the beginning and understanding the masticatory system. That's what we do, and you'll be interested in this, Howard. That's what we do in our Seminar 1 that I've been teaching since 1961. However, it's not the same seminar because we've learned so much since 1961. But here's what you're going to find interesting. You know, we spend 3 days going over all the principles of the concepts of complete dentistry, which include occlusion and the relationship of the teeth to the joints and all those things. And it's been my feeling that it's almost essential that these young dentists out of school spend those 3 days with eyeball to eyeball with us, so we can, we can really influence them, answer their questions, and help them understand not only the importance but the rationale behind it, because there's no mystery about it. The mystery comes from misconceptions about it. But here's what's interesting. We found this younger generation loves the online classes, you see. We said, well, we can't have them do online classes and get the same thing out of it that they get with eyeball to eyeball. Wrong. We're finding that if we can get the dentist to go through the first class of concept of complete dentistry online, when they come to the first hands-on class and they're really learning how to do some of the things that they've learned about, they're better prepared than they were when we were having them in the seat in front of us. And the reason for that, I'm told, is because we kind of burn out their brains on the 3 days of sitting there, whereas if they can do it online, they can take it bit by bit and repeat it over and over again. But we're definitely seeing a tremendous response in the dentists who are coming now through our total curriculum by combining online classes with hands-on classes.
Would you recommend that they read your book on evaluation, diagnosis, and treatment of occlusal problems before they do the online, before they see you live?
I would recommend they read my new book, which is Functional Occlusion, From TMJ to Smile Design. Yes, that would be a tremendous help to them because, they can study that from chapter to chapter. And what I say there, look, if you will understand chapter 1 to a point where you can explain it to somebody else before you go to chapter 2, and you go through the whole book that way, you're going to learn a heck of a lot of dentistry because it's all explained, and it's made very understandable with all the illustrations and case reports and all that.
So on the Dawson Academy, what is for the concept of complete dentistry, how long is the online module?
Well, it's equivalent of a 2.5 day course.
You have the 2.5 days online?
Yeah.
Oh my! You know what might be the best marketing thing we could do for these kids? We have 217,000 of them on DentalTown. You should. We put up 360 one-hour courses, and they've been viewed 600,000 times. You should put the first hour or two on DentalTown, and then if they want to read the rest, click here, and then go to your site and sign up for the rest of the 2.5 days online.
We have a lot online. We have all kinds of things online that introduce them to different concepts and all. And Howard, we're really excited about a book that we're finishing up right now involving my entire faculty. And the title of that is The Complete Dentist.
And and rumors have it that it's politically incorrect, because the one thing you'll learn from going to any of your lectures, you don't have any punches hold. You tell everyone exactly what you think. Right.
And it is politically incorrect because here's what we're saying. We're saying usual and customary dentistry, yes, it's improved, but it's nowhere near where it should be. And we see too many shortcuts taken where patients do not get the full benefit of what they should with a dentist who's really trying to get mouths healthy for the long haul.
So let's a lot of times when you're 25, you're not ready to learn because you don't see it yet.
You don't know what you don't know, yeah.
Right, you don't know what you don't know. So walk them through there. I mean, when does it go from I can take a single quadrant impression of one tooth crown? The tooth most likely crowns a first molar. So she's going to go in there and prepare a first molar for a crown and take a quadrant impression. When does it go from a quadrant impression to full mouth impression to mount it on an articulator? When does it go from one tooth dentistry to complete dentistry?
We can't look at it that way, because even one tooth dentistry is at risk if you don't know how the whole system works. And what we're seeing today, and seeing it a lot, is these new materials, the CAD/CAM materials and all, that are so hard that they can't cut them. If they don't understand how that fits into a total harmonious occlusal relationship, they put these crowns in there and they're high and they can't fix them. And of course they're glued in with resins that they can't break loose. So what a lot of the new technologies are doing are enabling dentists who don't understand how that whole mouth works, it's enabling them to screw up mouths faster.
And you and I have also, when I got out of school in '87, there were 15,000 dental laboratories. Yeah. Now there's half that number.
Yeah, right.
What do you think of the state of the dental laboratory?
I think they're getting better and better. I think we work with some extremely good dental laboratories, and they're loving what we teach, because what we teach dentists to do is to give the technician what he or she needs to really give them back something that works, and they don't have to guess at what they're doing. We don't leave anything to chance with the quality control procedures that we teach, because we put quality control into a three-part thing for the dentist. He has to determine exactly what it is he or she wants. Now let's say anterior teeth. They have to determine exactly where the incisal edges go. They have to determine the inclination. They have to determine the anterior guidance. All those things, we give them very specific ways to determine. But then if they determine those and they're making crowns or anterior bridges, what good does it do them to determine them if the lab technician doesn't know what they've determined? So the second part of the quality control is we give them also methodologies for communicating to the technician exactly what they have determined is needed. And the third part of that is that it's done in a way that's verifiable. So they have to determine what they want exactly. We teach them how to do that, whether it be posterior teeth, anterior teeth, aesthetics, whatever. And the second thing, communicate that to the lab in a way that it can be verified with absolute preciseness by the technician and by the dentist. It takes all the guesswork out of doing. The labs love it because they're not having all these remakes. The dentists that are following these concepts are finding their production spiking because they're not having to do things over. An awful lot of dentists spend a humongous amount of time jawboning with patients, trying to talk them in to getting used to something that just isn't right. We say if you have to talk a patient into getting used to your dentistry is not right. And that's a fact. I mean, that's not pie in the sky.
So when does your book come out, The Complete Dentist?
Within the year, probably within the fall.
Well, I hope you send us a book review to publish in DentalTown magazine about your new book.
I'll do better than that. I'll send you a personal copy.
Well, it'd be great to have a book review in the magazine.
We'll do that too.
Do you want to write your own book review, or did you want someone else to write it? Or
either way, we got plenty of people can do it, or I'll do it.
I'd love to have you do it. That is amazing. By the
I'll
way,
do it. I'll do it.
And by the way, congratulations. The American Dental Association gave you the Distinguished Service Award this year. That is
They're going to.
What's that?
They're going to. That comes up in October.
Well, that's got to be the biggest award in dentistry, isn't it?
Well, it's pretty nice, I'll tell you. I'm very honored by it.
That is an amazing award. Congratulations on that.
Thank you.
So So you're talking to a bunch of, thousands and thousands of kids, probably between 25 and 30. Explain to them how they go on a journey from one tooth to doing quadrant dentistry to doing full mouth dentistry. What are you thinking they have to do? They should read your book.
Yeah, let me back up again and go at you another way, because I think it's a mistake to start with thinking, well, you learn how to do one tooth. You can't do one tooth properly unless you know how that one tooth fits into the total scheme. The starting point is to understand occlusion and what it takes to have an occlusion that's in harmony with the joints and the muscles and all that. That's the only way you have any predictability. You see, I'll tell you the problem. The problem is dentists are trained to sell commodities. They're trying to sell the single tooth. That's what you're talking about here. Well, why don't we look at it differently? Why don't we say our job is to get mouths healthy and comfortable and in such harmony that they can be maintained in good health. Do that and then put the teeth into that picture so they fit right into that harmonious relationship. Now we got something. And that's true whether you're doing a single crown or a filling. Doesn't matter. See, and the other thing almost no dentists know how to do is to equilibrate an occlusion. Equilibrating an occlusion is the most conservative way to solve an awful lot of orofacial pain problems and loose teeth problems and wear problems and just general dysfunctional problems, and to bring that occlusion into harmony. And dentists don't know how to do that. In fact, a lot of them are being taught, well, don't dare go in there and start grinding on teeth. That would be terrible. No, that's the most conservative thing you can do, is to get that occlusion right so that there's a harmony. It's totally comfortable. You see, if your occlusion is not 100% comfortable, it is not right. Period.
So a good start would be to get your book, Functional Occlusion, From TMJ to Smile Design.
That's a great start, yeah.
And read that. Then the second start would be to go to the DawsonAcademy.com and start where you have 2.5-day online courses.
Yeah, or they can sit down with us too. They love doing it. I mean, they love coming to that. But if they contact the Academy, well, they'll be directed to the step-by-step process from there.
So another question that they ask a lot is, when you started doing complete dentistry, you were evaluating joints with a pano and a ceph. Today we have 3D, CBCT, cone beam. Do you think that's an investment? Is that a big part of understanding the joints, seeing them 3D?
Well, it's a tremendous improvement. Every dentist doesn't have to go out and buy a CBCD, but they have to have access to it, because today nothing can hide from us. We were flying by the seat of our pants on a lot of TMJ problems for years because we couldn't see in there, you know. But now we can. I mean, nothing can hide from us today. So we not only can diagnose every type of TMJ disorder, we can pin it down and classify it specifically. And until we've classified exactly what's wrong in the joint, then we don't really know how to treat it. So that's a starting point. And all occlusion starts at the TMJ. Because if the joints aren't in the right place, how the jaw comes together isn't going to be right.
Another question they ask, they come out of school with $350,000 of student loans.
Yeah.
The average practice being sold is about $650,000. So they're finding themselves, 27, 28, and $1 million in debt. So they're always asking financial investment questions. Another one they ask about is the tech scan. That's about $10,000. Do you need that?
No, you don't need it. It's very good. We use it, but that's not where you start. I work with graduate students at the University of Florida. In fact, we have a graduate school right here in St. Pete, University of Florida, and I have all the graduate students over to my apartment for dinner once a month. So I get to really into their heads and find out what they're thinking about. And they want to start their own practices. Well, I tell them what I did. I started with one chair, a dinky little office, didn't run myself into a huge amount of debt, and I started by taking good care of patients and building it from there. And as I was able, I built my practice. The dentists today want to go out, and right after they buy their Mercedes, they want to buy their 3-chair office. See, it doesn't work that way. And you don't have to do it that way. You can start very economically and just take care of patients. But the first thing they want to cut is the last thing they should cut, and that's the complete examination. Look what these dentists are doing, 15-minute exams. You can't examine a patient in 15 minutes. You can't tell a patient what they really need in 15-minute exam. So if you're not giving a complete examination to your patients, you can't even advise them on how to get their mouth healthy. But what we've found is if they will do a complete exam and really help their patient understand every problem they have and the implications of not taking care of that problem in a timely way, patients are very, very receptive to doing what's necessary. And only when the dentist does that can he even phase treatment for patients who can't do everything at once. So it all goes back to the complete exam and treatment plan. And that's the first thing everybody wants to cut when they go into practice. Wrong.
Well, Pete, what percent of the dentists in America today are still doing new patient cleanings, where it's a new patient, they call up, they schedule them?
I don't know what that percentage is. You might know better than I, but I'm absolutely opposed to that.
Right.
Dentists ought to see the patient, talk to them, find out what their needs are, look at them with, I'm a firm believer in the Christian viewpoint of loving one another. You're not loving a person if you're shorting them on helping them understand what they need to get their mouth healthy. So I'm going to sit down with them, help them understand their needs. They say, well, we don't have time to do that. Baloney, you got plenty of time to do it because it pays off. And besides that, it's the right thing to do. And so if they will do that, they will find they don't need as many patients as they think they need to have a very, very successful practice.
It's true. It's the complete exam. You've been preaching that since I first saw you lectured in 1987, and it was in Phoenix, and it was so good, I went and caught your next course 3 months later in the same year in Las Vegas. Just amazing, life-changing events. You also, in your lectures, you talk a lot about the work-life balance, and you and I both know in this profession there's a lot of burnout. There's maybe 14% alcoholism. Some people, there's too many suicides in dentistry. What do you think about the work-life balance in dentistry? Some dentists think that they have the most, stressful profession out there.
We preach work-life balance in all our seminars, and we preach about knowing when enough is enough and not being sucked into this idea that this practice management baloney, that your job is to sell as many patients as you can cram into your office, as much dentistry as you can sell them. That's where the stress burns out, and they're trying to run around working with 3 and 4 and 5 operatories instead of taking proper care of fewer patients and having a life. You can make an extremely good living in dentistry being honest, charging fair fees, and just being efficient in what you do and not having to do a lot of stuff over and over again. So we preach this idea of knowing when is enough, and I've developed a concept called a practice matrix, where you decide on your lifestyle first, and then you make your practice fit that. Too many dentists give their family what's left over from a practice that is poorly run and overly loaded with wasted time. That's the other thing we see. And I'm just reporting what we see from all of the contacts we have with so many dentists. That's why this book is politically incorrect. We're just calling a spade or a shovel, whatever. But it's this idea of seeing too many patients and thinking you have to see everybody is what burns you out. Make your practice fit the lifestyle that you want. You can do very well at it.
I'm old school. I have 7 restorations in my mouth, and they're all gold. Do you find it kind of ironic that American women decorate their entire body with gold earrings, gold wedding rings, gold earrings? I mean, they have gold on every part of their body, and then they decide that when it comes to their teeth, they want tooth-colored restorations. Do you find that kind of ironic?
I do. I agree with you. I've got gold restorations in my mouth. I put gold restoration in my wife's mouth. Gold properly done is beautiful and is not anesthetic if it's done properly. It doesn't have to shine back at you. But I like the new materials we have that are tooth colored if they're properly used, So, but I mean, we have options, but gold, nothing I don't think is ever going to be quite as good as gold for just hanging in there,
It's the only dentistry I've ever seen that can last 50 years and look brand new.
It'll last a lifetime. Dentistry done properly with an occlusion that's proper will not wear out.
I want to ask you
that sounds like a phony statement, but it's not. It's true. You cannot wear out a perfected occlusion unless you're chewing on some grit or something. You will never wear out a perfected occlusion.
So I want to ask you another, do you agree or disagree? It seems like when I got out of school in the 80s, the average restorative filling was an amalgam, and it seemed like they were always lasting 25, 35 years.
Yeah.
And then we had this cosmetic revolution, and we replaced it with a bunch of plastic resin that it looks like in the data is only lasting about 6.5, maybe 8 years. Do you think the aesthetic cosmetic revolution actually cut back the life expectancy from amalgam to resin?
I think it did in a lot of ways, but I think now we do have better resins. But here again, I sound like a broken record, but a lot of the wear on those resins is because of occlusal interferences and interferences in the way the jaw works. They're wearing them. You won't wear out a perfected occlusion, but when you put those soft materials in, even food will wear those.
When you're talking to your students, and you talk to so many, what do you think are the major misbeliefs that you see in TMD and occlusion? What do you see out there that you think kids believe that's just not true?
Well, I think the worst of the belief is that you should build all your occlusions to just maximal intercuspation, disregarding where the joint goes. That's the number one fallacy, and it's prevalent. And they say, well, why should you tell a patient where to move their jaw? Well, your muscles in a coordinated pattern are going to seat the jaw joints into centric relation, and that's where centric relation is the only place the jaw joints can be without having interferences to the bite. What we do not want is we do not want to close down on the teeth before the joints are fully seated, because now you're overloading the teeth. But more than that, you're hyperactivating all the elevator muscles. So you're creating more, this idea that you build teeth to support the joint is totally backwards. The teeth want to be in perfect harmony with that completely seated joint. And a lot of people who don't understand centric relation will fight that and say, oh, that's, you're shoving that jaw up there. We don't shove jaws. We gently manipulate the centric relation, and then we load test to verify. But a lot of misconceptions about that. And I think the other gross misconception is so prevalent is this idea that so much of orofacial pain is nothing but psychosocial stress. Not so. It can be a contributing factor, but I don't know that I've ever even seen it as the primary factor. There's always a reason for occlusal muscle pain or orofacial pain.
One of the things that's really exploded in America amongst the consumers and now the dentists is sleep apnea,
Yeah.
CPAPs. It seems like you can't read a Sunday newspaper anymore without reading some article on sleep.
Yeah.
But there's a lot of TMD experts that are saying that anybody who bruxes, anybody that grinds their teeth, needs to be sent for a sleep study. Do you agree with that or disagree with that?
I don't agree with that, but I do know for a fact from studies that bruxing is a component of sleep apnea, that we do see that, but you can't grind your teeth unless they're in the way of how the jaw moves. So here again, a lot of grinding and bruxing is a result of just teeth being in disharmony with the joint, and it's kind of an erasure mechanism that the muscles are trying to get rid of those interferences that require the joints to displace to get the teeth together. It hyperactivates the muscles. I mean, we can show that with EMG studies over and over again. And we can show how those muscles just quiet right down when that occlusion is perfected. But I'm a big believer that sleep apnea and dentistry have a very, very good place to be together in right proportions. But here again, we see dentists jumping in and making all these appliances, advancing the mandible without having a clue what they're doing. Making appliances for airway, increasing the airway, is a very precise procedure that shouldn't just be guessed at. We teach it how to do it right. We see more of it being done wrong. And done properly, dentists are more and more becoming part of the team that treats sleep apnea, because most of it, I think, if I can't positively swear that it's most, but I think it's most of the sleep apnea patients could be very well treated with appliance therapy, properly done.
So I would say there's 211,000 Americans alive today licensed in dentistry, and I believe that about half of them do a new patient cleaning. You know, when a new patient comes in, they do a cleaning and try to take the bite wings or whatever and do a 5-minute exam. But I would say that at least half of America, if you tell the dentist you're grinding your teeth or you see any bruxism, they're just going to take an impression and make an occlusal
Yeah.
guard or an NTI. What
Yeah.
do you think when someone comes in with bruxism and grinding and wearing their teeth, and you give them an occlusal night guard or an NTI? What would you tell that kid?
Well, first thing, that's not the way I'd do it. If they're grinding their teeth, I would find their centric relation. That's where the jaw joints go. I'd take a bite record there. I'd take impressions, and I'd analyze what do we have to do to the occlusion to eliminate that in those interferences that are creating a lot of discomfort. And you know what the number one reason people break down their teeth? It's called occlusal disease. Occlusal disease is excessive wear. You don't have to wear your teeth out. You wear your teeth out if they're not in harmony with the joints. You don't have to have loose teeth, cracking your cusps, sore teeth, sensitive teeth, all the hyperactive muscles, temporal tension headaches, all these things are related to occlusal disease. It's a direct result of disharmony in the system that hyperactivates the muscles. The teeth are sensors. They're made of neurogenic material. They're almost entirely nerve tissue. And they are sensors for the neuromuscular system. You put the teeth in the way of how the muscles want to move that jaw, and something's going to act up. And that's where you get the headaches, the sore teeth, and all those things are correctable, predictably correctable by dentists who understand occlusion.
I'm sure you've noticed there's now a wave of dentists going across the United States lecturing that TMD is best taught with Botox neuromodulators being injected into the muscles. What
that is? You know why? All they're doing is they're taking those muscles that are hyperactivated by occlusal interferences and they're paralyzing them so they can't. And they say, well, they quit hurting, so therefore we solve the problem. They didn't solve the problem. They just covered up the sensory system that's telling them they have a problem. So they can go on tearing their teeth up and feel like they've done something. But that's a good example of not understanding how the system works.
Well, probably then same answer for there's also a lot of people that are trying to treat this with pharmacological.
Oh, absolutely. We use almost no pharmacological, maybe up front if there's really in severe pain, but almost never do we need pharmacological approaches to TMD unless it's an intracapsular structural disorder. But, 90%, I'm sure this is right. I'm absolutely sure this is right. We're in the 90th percentile of patients with so-called TMD or orofacial pain, where that problem is directly related in one way or another, maybe not 100%, but very often 100%, to occlusal interferences.
So what's your thoughts on the NTI?
The NTI is nothing more than an anterior deprogrammer. All it's doing is separating the back teeth, which are the triggers to the muscles. That's all it does. You separate the back teeth so they can't, see, they're sensors. When that posterior incline hits that requires the joint to displace to get the teeth into maximal intercuspation, it triggers the muscles into holding the joint down into a malrelated position. Now you got elevator muscles fighting depressor muscles, and you've got isometric muscle contraction, which results in pain. Correct the occlusion. You can do it. You can get rid of the pain totally. You put a cotton roll between your teeth and get rid of the pain, but all that's doing is helping you make a diagnosis that the problem is occlusal interferences.
So, Pete, what are your thoughts on the fact that the United States has this group? One of the 9 specialties is orthodontics, and there's almost 12,000 of them.
Yeah.
And Americans, they've built this huge factory that Americans just send all their kids through this factory, and they go through their ortho. And a lot of people wonder, I mean, it's changing the bite, it's changing the curve of speed, the curve of Wilson. What do you think of just the before and after of America's children after they go through 2 years of ortho?
Most of it's not good. And for very good reasons, because they don't understand occlusion. They try to make things look good, but they don't understand centric relation. They don't understand the role of anterior guidance. How many ortho cases do we see where we don't even have contact of the front teeth? No capability to disclude the posterior teeth. That's how we get the peaceful neuromusculature, is by having a perfect centric where everything hits simultaneously. But the minute that jaw leaves centric, the back teeth are supposed to separate. That's what shuts off all those elevator muscles. But you've got to have a proper anterior guidance to do that. And so I've been fighting with orthodontists for years. However, in fairness, we're getting some very, very good orthodontists today who are buying in to an understanding of occlusion and doing a very good job. In our new book, The Complete Dentist, we have a great chapter in there by orthodontists who do know the difference and are preaching to get off this old school of ignoring occlusion in the ortho. Dynamite chapter in there on that. No, I have, what the orthodontist doesn't know what he doesn't know. He doesn't see these patients. When we see them when they're 30 and 35 starting to break down, and they say, well, I had a successful result because they had a good smile, but they don't hold up.
By the way, we send DentalTown every month to all the general dentists, and our other magazine is OrthoTown, where we send to all the orthodontists every single month, all the way since 1994. If you ever want to write an article just for orthodontists, you can address them. You know, it'd be such an honor to have you grace our magazine with an article from you. But if you ever want to reach all the orthodontists or all the general dentists, I mean, we have 2 separate magazines that do that.
We wrote this new book specifically to do that, because you see the problem here is you can't just take one aspect of complete dentistry and say, you fix this and everything's good. That's why it almost takes a book and say, but here's the problems we see. Here's what they cause. Here's how do you fix it. And we're saying, we're looking at our worldwide opportunity to see what's going on and reporting on just the facts. And saying, here's all the mistakes we see routinely. Here's how to avoid making those mistakes. And that includes orthodontics, includes orofacial pain, includes TMJ disorders, aesthetics, the works.
So I'm on DentalTown, and it has 217,000 members have posted 4.5 million times, and we have a search bar. And I do a search for just Dawson, and it just goes on forever. And there are so many threads. I mean, you can scroll people talking about you. I don't think you could read every thread about Peter Dawson if you went 24 hours a day and just read for a month. And so many of these questions I can't really ask because they're too they're so specific that it'd be too confusing. But I just want to tell you that whenever anybody talks about TMD and occlusion, you are the man. You're the everybody's only pretty much debates what you are saying.
Huh.
Have you ever seen any of those threads?
I don't think I have.
You should get on there. You should get on DentalTown. It's free, or you can download the app on your phone. But you just got to Google your own name and just see all the questions they have. I mean, like today, on TMD. Where's let me just go under TMD occlusion. I'll just read you a sample question. You want me to read you one?
Sure.
I'm on today's active topics. Okay. So the topic is some confusion after reading Dr. Dawson's book. I am currently reading an article on occlusal wear by Dr. Peter Dawson and find a bit hard to understand some of the contents. The moment the jaw moves forward, left, or right from CR, all the posterior teeth are immediately separated by the anterior guidance. The posterior disclusion is part of the magnificent design of the masticatory system that shuts off most of the elevator muscles as the lateral pterygoid muscles contract to move the jaw from CR. This posterior declusion, in combination with a perfected anterior guidance, reduce muscle loading of the TMJs and reduce the potential horizontal force in the anterior teeth. Number one, I just don't understand how the posterior disclusion, in combination with anterior guidance, reduces muscle loading of the TMJs. Number two, how does posterior disclusion shut off most of the elevator muscles?
Well, that's a good question. See, what this person asking that question is not understanding is that teeth are sensors that control the neuromuscular system. Gene Williamson is the one who did the original study showing, with very sophisticated EMG studies, that when the back teeth separate, all the elevator muscles shut off, except the anterior fibers of the temporalis. So it's built in, because remember, at that point, the anterior guidance takes over, and that's all horizontal forces. So if you were designing a system to reduce the horizontal forces on the front teeth, wouldn't you just shut down the power? And that's what happens, you see. So it's built there. Everything in this design has an intelligence to it. Intelligent design of the masticatory system. Everything has a purpose. And so when you have posterior disclusion, you cannot wear out your back teeth because you can't rub them. You can't rub your back teeth. You can only touch them in centric if you've got a perfected occlusion. That's why you can't wear them out. Doesn't affect you. You have no problem chewing that way. But that means then your anterior guidance has to be done perfectly or it will wear out. That's a whole nother subject. But we can tell you how to make an anterior guidance that doesn't wear out by making it in perfect harmony with the envelope of function. And there's all kinds of guidelines we can give to be very precise in how that's done. But if the anterior guidance is done right and it doesn't wear out and you have posterior disclusion, the back teeth can't wear out, you not only have very peaceful neuromusculature, but you've got teeth that aren't going to wear out. And they don't.
So he goes on to say, from my understanding, is the mandibular movement also guided by the inclination of the cusp of the posterior teeth?
No.
Said that, should the posterior teeth also have contacts during jaw movement from CR?
No, you want them discluding. It's a mistake to think that teeth dictate where the joints go. The joints are pulled up into centric regardless of where the teeth are, or no teeth. All the elevator muscles are behind the teeth. They're going to seat the joints. If the teeth get in the way of that, then the joints have to displace to get the teeth together, and then you've got these little lateral pterygoid muscles trying to hold this condyle down this slippery incline while all the elevator muscles are working against them, and you got muscles fighting muscles, and the muscles get sore and overactive and incoordinated.
I just emailed you that thread. Like say, if you go into DentalTown and just Google, search your own name.
Yeah, I will.
You'd have to write another book to answer all the questions. Another question someone's asking under TMD. Have you ever had a case that was so inflamed that you needed to prescribe them steroids to calm them down?
Yeah, but it's very rare. That would be very often, that would happen when you've had a trauma to the jaw and you have created some edema in the retrodiscal vascular tissue up behind the joint. And that's the case where we would prescribe some steroids and soft diet, and maybe that's the only occasion where we'd use an anterior advanced splint. We would hold the jaw slightly forward just to get the condyle off of that retrodiscal vascular tissue until it could heal. But we don't want to keep it there. We want to let it get back up as soon as we can, because if we don't, it creates adhesions and scar tissue back up there. Then you've got another problem.
Another person is asking you, obviously if a child had a cross bite, you can orthodontically fix it. But what do you do when it's an adult and they have cross bites and things that you could, what are your thoughts there?
Having a crossbite doesn't mean there's anything wrong. It might mean just the mandible is bigger than the maxilla. You can have an absolutely stable, comfortable, maintainable bite that's a crossbite and not an aesthetic problem either. So we don't go in and change every patient just because it's crossbite. That's this whole concept. Well, make everybody look like the textbook. You don't have to do that if you're working with understanding that what you're really trying to do is create a harmony that when the teeth come together, they're in perfect contact, simultaneous, equal intensity contact at the moment the jaw comes together and the condyles are completely seated. That's what we're after, whether it's crossbite or not. Class 1, 2, or 3. It's a mistake to think that the classification of occlusion is even significant in creating orofacial pain.
And what would you call your occlusion, your model of occlusion?
Harmonious occlusion.
Because a lot of people refer to your type of occlusion as CR. Do you?
Well, CR is the position of the joints. That's the starting point. Centric relation. Yeah, a lot of people do refer to it as centric relation occlusion. Because if you're not starting in centric relation, you are automatically building in interferences to the bite.
But what would you prefer your occlusion be called? Do you prefer harmonious occlusion or CR, centric relation occlusion?
Either one, doesn't matter.
Either one. Also, neuromuscular. I don't. It is a huge topic. What did you think of Dr. Bernard Jenkelson's? Was he the inventor of neuromuscular dentistry?
Well, I'll tell you a quick story. Yes, he was the inventor of it, and he was a friend of mine, and we were members of the Equilibration Society when there was only about 100 members. And he came up to me and told me about this new gadget he had. Well, I had a think tank group going on down here in St. Pete, and he said, this thing gets centric relation. And so I said, well, Bernie, why don't you bring it on down to St. Pete? I'll get some patients, and we'll have a look at it. He said, okay, we'll do that. Well, Sig Ramford was standing there. He says, I want to come too. So Sig came down with Bernie and me, the three of us. I got 5 patients, and Barney started working his myomonitor, and he couldn't do it. He couldn't get centric. It was everything was advanced because he was activating muscles into contraction, pulling the jaw forward. And he said, there, that's what you're supposed to get. And Sig says, Barney, that's not centric. And we were doing it with Bunograph, so we could see where the joints were going with his thing. And he was missing centric by 1/4 of an inch. And he said, well, that's where it should go. And I said, no, that's not where it should go. You're going to end up muscle brace. He said, that's not centric relation. He said, well, we'll call it something else. We'll call it myocentric. That was the start of myocentric. It was wrong then. It's still wrong. It builds malocclusions by building teeth that require the joints to displace to get them together. It advances the mandible, so the condyle has to come down to go forward, so they're building up all the back teeth back to contact. It results in building complete mouth reconstructions for people who didn't need them. So it sells a lot of unnecessary dentistry. I think it's...
Oh my God, Pete, if you wrote that in a 2- or 3-page article for DentalTown magazine, that'd probably be the most read, most controversial article I've ever published since 1994.
You're kidding.
Oh, please, will you please write that story for me? Because these kids that come out of school, the first fork in the road they come to, and they're all asking at every school, well, should I learn CR or neuromuscular? They don't want to go pay $3,000-$4,000 for a weekend course and be in the wrong camp. So it is the most asked question.
You're kidding.
By the dental graduates.
I thought neuromuscular had died a death because
oh my God,
there have been so many problems from it.
Pete,
I mean, there have been probably more neuromuscular cases that had to be rebuilt than anything that's ever happened in dentistry.
Pete, if you go into DentalTown and search the word neuromuscular, you couldn't read all those questions. You couldn't read them all between now and Christmas.
That's a perfect example of The kid's getting sucked into something that's dead wrong because they don't know how the system works.
So maybe you'll write that article?
Dental school should start out teaching masticatory system function. How do you know how to, if you don't know how the system works, how do you know what's wrong with it when it isn't working? How do you even know you're not causing it problems? You don't.
Well, do you think you'd ever answer that question in an article?
You know, I spent a lot of time writing articles. We put out a lot of blogs too, but I'm passionate about getting the word out because there's so many patients that are being hurt by these kind of problematical approaches.
I would just say this. We mail a 100-page magazine every month to all 125,000 general dentists since 1994. The data shows it's the most read.
Yeah.
It is I can tell you, it is the most asked question of dental school graduates. They don't know if they should go, which path they should go down because these, they just don't want to go down the wrong course.
Yeah.
And like you say, they don't have that question in endo. They're not afraid that if they go to an endo course, they might go down a different philosophy.
Well, the other thing is they're being sold a bill of goods that they can make a ton of money by going into this neuromuscular dentistry because it's all complete mouth reconstruction. That's not where you start out, you know. I'll
tell you another article that you should write. You know how many periodontists and oral surgeons are afraid to tell their referring dentists? A lot of times an implant will break or it'll snap. And the periodontist is saying because the restoring dentist doesn't know occlusion. And the referring dentist is asking, well, was that some cheap implant or was that a knockoff or
no? That's another really good chapter in our Complete Dentist book because the problem is that implantology is a prosthodontic discipline where the restorative dentist has to determine where the teeth should be before the implants are put in. If the surgeon or periodontist is just sticking them in wherever he can find bone, it may have nothing to do with where they should be. Here again, you have to understand what it takes to have harmonious occlusion. There's a lot more to occlusion than just the joints. I mean, you got neutral zone considerations, anterior guidance, all these things that have to be considered if you want this, harmony and something that's going to hold up and be comfortable. If you're not making all those decisions with proper treatment planning before you put your implant fixtures in, they're impossible to restore and without just ending up with some kind of atrocity, you know.
Another question young kids ask is, what are your first thoughts when a patient comes in and has painful noises, popping, clicking?
That's a sign that the disc is displacing off the condyle. It is always related in some way or other to occlusion because it's a muscle in coordination that has to pull that disc off the condyle. We can prove that over and over again. The louder, this is interesting, the more staccato the click, the easier it is to fix because that's an indication that the posterior band is still intact and is self-centering if you get the muscle coordination. Occlusal interferences activate muscle in coordination. You're pulling on the disc on one direction, pulling on the condyle in another, and you're pulling the disc off the condyle. Go in there and fix the bite and the click goes away immediately unless you wait too long and then the posterior band of the disc gets all flattened out and then you're pretty much stuck with the click. But a click is an indication there's disharmony in the occlusion. Now it can also be caused, from trauma. Very, very often is. The disc derangement is torn like a rear end collision, can tear the disc loose as the jaw snaps back and all. But it still requires the muscle in coordination to pull that disc off the condyle.
Another question they're asking, what are you thinking in your mind when you're about to go restore an adult who has an open bite?
Well, the first thing I'm going to do is find centric relation. Where are the joints? Then I'm going to look at the options that I have for getting the back teeth out of the way so the front teeth can contact in centric relation. Because if I can accomplish that, then I can get my immediate disclusion and have all that harmony. But there are other things to consider. Some open bites I want to leave because they're stable. See, we have signs of stability or instability that are going to determine whether we really need to go in there and change a bite. We don't change a bite just because it doesn't look like a textbook. We look, are there signs of instability? Because if there are, then we know the requirements for stability, and we'll say which ones are not fulfilled, and we approach it from that. But some people have a tongue thrust that actually is beneficial in holding that occlusion stable, and they don't need to have an anterior open bite closed. One of the other problems that we see in a lot of the orthodontics now is where they're shoving that jaw back, they're literally creating airway problems, crowding the tongue back there, you see. You see, you just can't take this masticatory system and parse it into saying, well, we'll learn how to fix one tooth, and then we'll go to 2, and then 3. You got to know the system before you fix the first tooth in there, before you fix the first anterior guidance. You want to, another thing, you know, the neutral zone is a tremendously important aspect of occlusion. That's what determines where teeth go. The outer force of the tongue and the inner force of the perioral musculature. You look at some of these television anchored, these beautiful girls, they can't get their lips together. The dentist in there has no clue what a neutral zone looks like, and they've got teeth that are hanging over their lower lip, and because their teeth are too big, they don't fit. And that's an aesthetic problem, but I can guarantee you the very best aesthetics you can do for a patient will also end up to be the most functional and the most stable.
One of the first TMD questions a new graduate will ask is, how far can you open the bite?
You can open the bite probably up to 10, 15 millimeters, but it's going to come back right where it was. You can't hold it open. The muscles will always control and close it right back where it was.
So the answer, so we now have 9 specialties, and a lot of the older endodontists were just had practice limited to endo, and then when they made it a specialty, they grandfathered them in. Do you think TMD should be a specialty?
No, I think it ought to be part of general dentistry.
What about implantology?
I think more and more general dentists need to become expert in implantology because it's more and more becoming a very useful thing. But I'll tell you what I am opposed to. I'm opposed to taking out all these good teeth and replacing them unnecessarily with implants, and I'm darn sure opposed to taking a mouthful of periodontal disease and giving them teeth in a day. You can't get rid of periodontal infection and all that in a day. And whether they're doing that or not, they're certainly advertising like that. I think it's disgraceful.
So you get rid of the periodontal disease, manage that.
I want a healthy mouth before you start putting restorative dentistry in it.
Yeah. So a lot of dentists worry that, you know, when I was a child, all the pharmacists owned their own pharmacy. Now they all work for Walgreens or CVC. How do you think corporate dentistry will take over the entire profession, or what percent, or what is your prediction, you know, going out 50 years?
Well, it's already 73%, I think it is, that graduating dentists are going into some kind of corporate dentistry. And I think corporate dentistry is really no different than, frankly, individual practices. You can have good ones or bad ones. We know a lot of corporate practices today that are working very hard to have their dentists trained to do things right. We also know probably more that are training them to produce as much as they can with quotas, which of course I'm totally opposed to. But the way we look at our Dawson Academy is we're thinking patients. And those dentists that are going into corporate dentistry and don't know how to take good care of their patients, they have to have some source of education where they can do a good job, because the fact that they go into it doesn't mean they're bad people. And it doesn't mean every corporate practice is a bad thing. Some are, some aren't. But I think I think it's here to stay.
Any recommendation if they want to go work for corporate? Who's trying the hardest to learn occlusion?
I think the individual dentist who makes up his or her mind to learn it, regardless of whether in private practice or corporate practice. It's an individual.
And then,
but there are some corporate practices that are promoting postgraduate education, so they will do a better job. I applaud that.
And another question people ask is, if I was going to have a complete dentistry practice instead of a usual and customary practice, where would I find, how would I get new patients?
First patient. You treat that first patient right, you give them a complete exam, you sit down with them, help me understand what your problems are. Okay, let me help you understand what's going on here. Co-diagnosis, show them their problems. Go ahead, probe the perio, show them what pus looks like coming out from under the gum, show them what a loose tooth looks like, show them where through enamel into dentin. And then here's the key, what are the implications? Here's the problem, you can see that, they don't have to trust you, you can show them. If you weren't trying to do the dadgum exam in 5 minutes, show them the problem and then help them understand what are the implications of not taking care of that problem in a timely way. The average intelligent person wants a healthy mouth. The average dentist wants to sell them a filling or a crown. Turn it around, get the mouth healthy. Patients respect that, they want that. That's the way you build a practice. If you do that, you don't even need advertising. You don't have to give away $5 bite wings either and call it a complete exam, you know.
So, and I'm sorry, you promised me to give me an hour, and I've already stolen an hour and 10 minutes of your precious time.
I'm having fun, though.
You're having fun?
Yeah.
I've had several dentists ask me over the years, is Peter Dawson, did he agree with everything LD Pankey said? Were they on the same page, or did they have slightly different philosophies?
I agreed with an awful lot of things LD did. LD, you know, like everything I started out teaching hasn't stayed the same. I've had to make changes in what I think as I learned more. LD came along at a time where he gave us some wonderful shoulders to stand on. But no, I didn't agree with everything. I didn't agree with the group function. We got off of, but I did it first because I started out with gnethology. And then I saw how much better that functional path was in clearing out interferences. But then having group function, we found out wasn't as good as posterior disclusion, so we had to change there. I had to make changes in anterior guidance from what Clyde Schuyler taught us because it needed some improvements, which I made. And that's another long story in itself, a fun story. But no, LD Pankey was a tremendous contributor and a great mentor and somebody who had a lot of influence on getting me thinking in ways that have been beneficial. But no, we didn't agree on everything. And I don't agree in classification of patients. I absolutely do not. I don't agree that you decide whether this patient is worthy of your treatment. I think if somebody calls me and comes into my practice, and this may surprise a lot of people, who say, oh, well, all you do is work on rich people. No. I work on a janitor. I work on anybody that makes an appointment, and I feel it's my job to help them understand what they have to do to get their mouth healthy. And I've got to know enough about that person to help them work out a plan that works for them. And if I do that, and approvable focus groups have shown, if I do that on 12 to 15 new patients a month, I can live a very, very good life, and I can take care of those patients that come in, because actuarially, out of 12 to 15 new patients who are properly examined, there will be more than enough dentistry to do to give me a very good lifestyle, especially if I don't have to do everything over or spend hours talking them into accepting something that isn't right.
Now, LD was from Kentucky, right?
Yeah.
You know, I'm so glad you mentioned that classification because that was the most major turnoff I ever had in my life. I came out of dental school. I was all bright-eyed and bushy-tailed, and I ran down to the Hank Institute, and they were telling me about, they're describing the A patient, the B patient, the C patient, the D patient. And when
Mm.
they got to the D patient, it was the entire Farran family reunion from Parsons, Kansas. And I'm
Yeah,
looking at these guys like, that was just so, it was offensive because,
yeah. Well, I'll tell you another thing where we disagreed. When they did the Pinky Man instrument, I had to tell them that it was a very poor instrument that did not do what it was supposed to do. And Jelenko had a carload of those things already made up. I had to show them why it was a bad deal. And you know what? Arvin Mann was upset. LD said, I never did like that thing. Arvin came up with that thing, and I never did like it, but they put his name on it. LD was a very honest guy.
Whereabouts in Kentucky was he from?
I forget the town he was from.
Small town Kentucky. So were you born in St. Petersburg?
I was born and raised here.
Born and raised. Did you survive that last hurricane?
Well, I was in North Carolina when that hit.
Yeah. So you've had how many hurricanes have you had go through your town?
Very few.
Very few.
Yeah. Well, I go back when I was a little kid. We had a pretty bad one, but we've had very few actually hit here.
So, last question. I'll let you go. Last question. So many of these kids ask, and they ask on DentalTown. They ask all the time. They ask. They say, Pete, I just graduated. I have $350,000 of student loans. I'm 25. Do you think that you and Howard graduated in the good old days? Do you think I made a wrong decision? Do you think that was a dumb idea to drop $350,000 and be a dentist, a doctor of dental surgery at 25 years old? Did I mess up, or do you think that was a good idea? And what advice would you give a 25-year-old carrying $350,000 of student loans?
Well, first of all, I think it's not bright that they got into that position in the first place, but now they've done it. I mean, they don't have to spend that much money to get through dental school, unless they're spending money they don't need. But regardless of the amount, let's face it, $300,000 is a very manageable amount to pay back for a dentist who's practicing properly. They need to go and start paying it down in a reasonable way before they buy the Mercedes and before they get all this additional debt. If they would do that, they would find exponentially it starts going down faster and faster, you know that, and they can pay it off, but they can't do it and build $1 million practice at the same time. So start small. That's what I did. I didn't have any money when I started practicing. I had none. I married for love, and Jody and I both owed for our college education. Now, it was true back then, a Coca-Cola cost a nickel and gas was 19 cents, but I only made $20,000 my first year in practice too, because that was, I was doing gold crowns for $35 and $4 for a filling. So these numbers now are probably not that much different from what we were faced with the inflation brought on.
But
because to think a dentist could be making $1 million a year or $200,000 a year, why, nobody even thought that could ever happen back when I started practicing.
But you're right. The only reason they have $350,000 of student loans is because somebody gave them access to that much money to borrow. Right. It's like if you gave every American 12-year-old a credit card, they'd all go max it. Yeah. I mean, in my day, I didn't have a car in undergrad. The first 3 years of dental school, I didn't have a car. We walked to school.
I didn't either. I drove an old used car for my first year of practice.
Yeah. We used to laugh at the editor of DentalTown magazine, Tom Giacobbe. He drove a car that couldn't have cost $1,000 for the first 10 years he practiced dentistry. We're going to go chip in and buy him a car.
I gave my partner, Glenn DuPont, when I brought him in, I gave him advice, don't spend money you don't have. Get out of debt first, and then you'll move ahead of everybody else that's trying to jump ahead of you now. He rode the bus to work for about 3 years before he bought an old used Buick.
Okay, I promise the last question, but I have one more last question. They always ask, when can I start my own practice? When I graduate from school, how many years do you think I should practice before I have the skill set good enough to buy a practice? Because the bottom line is, like with Bank of America, you qualify for financing. I mean, they don't even turn down 0.5% of people. So these kids they had access to student loan money. They have access to capital. They can buy any practice if it's in the range of about 650,000. But they always ask, how do I know I'm ready to buy the practice versus go to Army, Navy, Heartland, Aspen, Pacific Dental? How long should I work before?
I think it's a matter. It varies so much. We have dentists who could take one 3-day course and go out and just almost start doing it. We have others that could go through a whole curriculum and still be confused, And there's some that just have it and think properly. Others stay confused all their life. So you can't just categorize everybody in the same box. But I'd say when you feel that you know enough and you have enough confidence where you can sit down with a patient, properly examine their mouth and make a proper treatment plan, which we can teach them to do very, very well. When they get to that point, they're ready to go ahead and start their practice. And if until that time they have to go into a partnership or associateship or whatever to get started, I don't see anything wrong with that.
Well, again, it's the largest thrill in the world that you graciously accepted to come on this show, Pete. I've been a fan of yours since I've seen you so many times. I even had breakfast with you. You were so nice. You even let me have breakfast with you after I've seen you at in downtown Phoenix. I think it was 24th Street and Country Club at that nice, what is it, that hotel there? You probably remember. But just an amazing.
I've always admired what you're doing too, Howard. I mean, I don't know if anybody's made the impact that you have on just getting information out. So, same back at you.
Well, thanks, buddy. But seriously, you're a rock star, idol, mentor, role model. In fact, you're probably you're the Vince Lombardi of dentistry. I mean, more people have followed your guiding lights and principles when they came to a fork in the road than anybody I know. I mean, I've seen that for 3 decades. But again, it was an honor. It was a privilege. Thank you so much for all you've done. Remember, we have a DentalTown, OrthoTown magazine that goes out every month. And so obviously, if you ever, when your book comes out, you want to send us an article. If you want something different for the general dentist versus the orthodontist, whatever, just consider it your own property, your own magazine to do with what you please.
I'm probably going to take you up on that as soon as I get these other couple of books that I've got just about to wind up here. So get those off my back, and I'm always looking to express my opinion, whether you want to hear it or not.
That's what everybody always loved the most about you. You'd go out there. I mean, even when it came up to general elections, I mean, it'd be an election. Everybody always says, never talk about religion or politics. I've seen you speak before several big contentious elections, and you'd be up there ranting about your political views, and everybody always say, yeah, only Pete can get away with that. If any other speaker said that, they'd get in trouble. But you've always talked right from the heart. You're always, I wouldn't call it politically incorrect. I just think you respected dentists enough to realize that they wanted to really know what you thought, and they respected you, and you respected them to tell them what you really thought instead of being artificial.
Well, thank you.
All right, have a great day.
You too, Howard. Great being with you.